So now we have a man of 70 complains of frequency and hesitancy of micturition with poor stream and urgency over the past 4 months. So frequency, hesitancy, poor stream, urgency. You should be able to know the difference between frequency, hesitancy, poor stream, urgency. You should be able to know. So sometimes they say that, oh, when I feel like urinating, within few seconds, I'll see some of the urine on me. In other words, we're just going to okay. They say that I urinate like almost every 10 minutes, 20 minutes, I'm urinating. You should know what it means. Sometimes too, the urine wants to come, but you are there, it's not coming. Okay. You go and stand in front of the your WC. You hold it and it's not coming. You should know what it is. And sometimes it will come, but it will come and then it will cut. Come and it will cut. Sometimes it's even painful. So all those terminologies, you must know what they are. All right. So they are saying that all of these things has now led to what? A retention of urine. It has led to what? Retention of urine a month ago. So retention means that the urine is not coming out, right? It's now stagnant. It's not moving. He had also experienced intermittent waist pain. On examination, he was well nourished, not anemic. On rectal examination, that is DRE, his prostate was enlarged, firm with some irregular areas. So again, GMDC is so kind to us, or it's so kind to you that they even told you what to even look out for, isn't it? And over here, they are telling you that start thinking about the problem with the prostate. So immediately, the wires in your brain should start connecting. Okay, it should start connecting. So prostate, what can I think about? So anything that prostate, just mention it. And you'll be good to go. Anything, whether infection, whether cancer, whether everything can cause what? Retention. And I'll show you why after the presentation. I'll show you something. When we are done with this particular question, I'll show you something. All right. So basically, start thinking your mind around the what? The prostate. Okay. Now, what is your working diagnosis in this setting? Definitely, you are thinking about of a prostate cancer. Prostate cancer. All right. Then, now, someone can argue with me. Yes, it can be BPH. Of course, it can also be BPH. It can be BPH. But again, if you look at the irregularity of the mass that is being presented to us, we can't be looking out for what? A cancer. Cancers are normally what? Irregular in shape. Okay, normally irregular in shape. That is why immediately what comes to your mind is what? It's a cancer. But of course, it comes to what? BPH. All right, so 3 differentials. Definitely, BPH should be part of it. That is benign prostate hypertrophy or hyperplasia. Hypertrophy and hyperplasia. And by now, there's no difference between hypertrophy and hyperplasia. Plasia, this is what? Cells. Trophy, this is what? Size. So the size of the cell is growing, or the cells are growing in number. So size and number, they are 2 different things. So it can be benign hyperplasia or hypertrophy. Okay. Then, like I said, it can be what? An infection in the prostate, right? So for 4 months duration, then you're thinking of what? Of a chronic prostatitis. Chronic prostatitis. Then you can think of what? Stones inside the prostate called what? A prostatic calculi. So these things, never forget them. So again, BPH, chronic prostatitis, prostatic calculi. These things, you should mention them. All right. 3 useful investigation you will do, or diagnostic investigation. 3. Again, this organ is what? Anything, how do you call it? Viscera and things like that. I've told you already. What do you do first? or what the most important thing that will you do? If nothing at all comes to your mind, what will you do? Of course, the ultrasound, the ultrasound, the ultrasound. So definitely you want to do what? Abdominal pelvic ultrasound. Abdominal pelvic ultrasound. Then you would like to do what to call what? Your transrectal ultrasound or ultrasonography, or the TRUS, transrectal ultrasonography or ultrasound. Then you can do your radionuclide bone scan. Radionuclide bone scan. You can also do your PSA, right? PSA, that's the prostate specific what? Antigen. You can also do that one as well. So these are useful investigations you might want to do. Again, abdominopelvic ultrasound, transrectal ultrasound or ultrasonography, radionuclide bone scan, then PSA, prostate specific antigen. These you might want to do them. All right. 3 modalities of management. 3 modalities of management. So people come to you, you are a doctor or a house officer, they come, Charlie, and you know that the person is having what? A prostate cancer or a BP, whatever it is. What are you going to do for this patient? For some people, we can do what to call what? An observation. You can just observe the person. Okay. So it's not all cancers or all urinary retention that you might want to treat. Okay. Or how do I even put it? I'm saying it's right. Sometimes I just want to observe the unit itself will start coming. Sometimes I just have to pass a catheter and see how things work. So that's also part of what we call the watchful waiting. So you can pass a urethral catheter and observe, and observe, and observe. Okay, so that's one of the modalities. So watchful waiting, watchful waiting, watchful waiting. All right. And sometimes during the watchful waiting, you can also give some medication. They're all part of the watchful waiting. Okay. I don't know if you can know what that tamsulosin. They are all there. All right. You're going to do what we call prostatectomy. Prostatectomy. So radical prostatectomy. Prostatectomy. So you removing the prostate is also what? A possibility. Removing the prostate is also what? A possibility. Then since it's a cancer, you can do what we call what? A radiotherapy. 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 So again, watchful waiting, radical prostatectomy, radiotherapy. These things you should or should form part of your treatment modalities or your management modalities. But if you really, really, really want to treat this patient, just remove the prostate. That's what the prostatectomy. So that's the definitive management. But sometimes it's expensive. Old age, 70 years. What at all do you want again? So sometimes they say, oh, just allow me to die. Okay, except for those who are still young, vibrant, and they want to, you know what I mean, enjoy life and things like that. They might want to, get it sorted out. But nobody wants their prostate removed. Anyways. Okay. So like I said, I will show you how what we are saying is the prostate. Now look at it. So this is the male reproductive organ. Okay. So this is the male reproductive organ. Then over here is the bladder. So the bladder is where urine is what? Is stored. So of course it comes from the kidneys. Then it stores in the bladder. Then in the bladder we have this thing over here. That's the urethra, right? That's the urethra. Passes into your penis, then into the outside world. Now this urethra passes through or is in between the prostate. So this is your prostate. This is your prostate. You see your prostate. This is your prostate. But in between is where you have what? Your urethra passing, where the urine is coming. So imagine there's a problem over here. Imagine there's a problem over here. I mean that the urine here cannot come out. It can come out, right? So you see that your suprapubic area will be bulgy. Or you see the patient, that area, suprapubic area will be bulging. And that is why in this question, they said the person was having a waist pain. That can also lead to waist pain. Trust me, it's excruciating. Okay. One time I was at the ER The patient was shouting. I just went there to just, even the catheter was not going, catheterization was not effective, or it didn't go through. So in that, what did I do? I just created a path on the suprapubic area. So I just used, we didn't have any instrument, we just used the needle, how do you call it? A cannula. Those who have been at the ward, you know, we have ash cannulas, a little bit big than the green and the rest. So I used an ash cannula to just punch on the suprapubic area where the bladder was, and immediately fluid or urine started coming out, and the patient was relieved. I think I withdrew about 400 to 500 mils of urine. Patient was so happy and so free, so relieved. At that point in time, there's nothing we could do than to do that. But later on, we have to create a path over there. So cystotomy, we have to create an opening for him to urinate whilst we do the surgery for the person. Okay, some people catheter helps them. So we put a catheter for them and they are fine. And those catheter can be there for months, even years before you remove it. Of course, you can go for dressing, they remove, they put another one. But you can be with a catheter like that. But you know, the men, they don't want it. Some people don't want it because they want to enjoy life more. I hope you understand, enjoy life. Anyway, that's it by the way. So again, so that's how it's supposed to be, your urethra. So urine passes there smoothly and nicely. But when there's a cancer, it begins to compress the urethra. So it becomes narrow. So urine coming here becomes a problem. So it starts creating pressure inside the bladder. And that's the pressure that the patient feel, okay, that there is pain. All right.